see it enough that I do warn families that if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal mucosa. For families or for children that are already growth restricted for whatever the reason, sometimes Nasonex is a nice option that I do does have the lowest systemic bioavailability. That if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal mucosa. For families, the other kind or of for children that are already growth restricted for whatever the reason, it has particularly good efficacy option that doesn't work with asthma and bioavailability. That if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal regarding a black box warning for families or for children that are already growth restricted for whatever reason. It has particularly good option for families bioavailability. That if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal mucosa. Black box warning for families or for children that are already growth restricted for whatever reason. It has particularly good option for families bioavailability. That if they're starting a nasal steroid spray, just be on the lookout. It can dry out the nasal mucosa. Black box warning for families or for children that are already growth restricted for whatever reason. It has particularly good option for families bioavailability. That if they're starting a nasal steroid spray, just be on the lookout. How long are we supposed to continue the medicines? Is this something that is, kind of chronic maintenance medication? Usually what I'll do is give them a course of about 3 months. Most of the studies, that use medical trials or medication trials look at about a 12-week course. And so usually what I'll do is about 12 weeks. And then if we're treating kind of an allergy component, I'll say, get through spring, for example, and then kind of taper once all the pollen hits, or get through fall. And then once ragweed kind of dies out, then go ahead and try to taper things off. In terms of looking at other non-surgical treatment options, obviously CPAP and BiPAP are options with, I would say, variable success depending on the study and the center. And honestly, probably depending on if you have a behavioral sleep person who can work with children, work with families, and increase compliance, comfort, and fit. In craniofacial children, mask fit becomes an issue. I know when I was at CHOP, there was some work being done looking at overall like 3D printing to specifically, shape a mask to each child's face, which has not made its way to Pittsburgh quite yet, but I think it's a great idea for these craniofacial children with really significant sleep apnea. There's limited evidence to suggest that maybe it's possible to create some craniofacial change. So if you do treat young children that you're going to recommend CPAP for, it's something to at least discuss with the family, I think. And then, obviously in very little babies, it's just, sometimes becomes a feasibility issue. In toddlers and young children, the families are generally pretty hesitant, just from a acceptance standpoint. But like I say, I would say referring to a good behavioral sleep team to really work with families in terms of acclimating to CPAP. It's sometimes a really good option to consider still. And then, the other, what I consider kind of underutilized treatment option that we're still, I think, just starting to really understand is really this rapid maxillary expansion. And I actually think that probably the skeletal structure is really the key to sleep apnea prevention in the future. Because if your tongue does not have somewhere good to sit in the roof of your mouth, it's going to just fall back. And so, a lot of times when we see these kind of early teen year children, hopefully we see them before they've kind of missed the window to be referred for orthodontics and really expand their maxilla. In terms of, when that suture line fuses, it's person specific. It's kind of orthodontist specific in terms of how willing they are to really try that expansion. Some people use the age of 13 to 15 as kind of when those palatal sutures fuse in the midline. And so if they've already fused in the midline for these older teenagers or young adults, then sometimes, it would require surgically splitting that suture line. So talking about, just touching on the other kind of surgical treatment options that we consider. These are things that sometimes is nice to, have a picture to actually see what the anatomy looks like a little bit. So, addressing the nasal airway, we essentially extrapolate a lot of our evidence from the adult world. And really what the adult literature suggests is that this can have a role for making a difference in terms of nasal breathing, daytime breathing, and also quality of sleep. Even if the goal is not necessarily to cure the sleep apnea, it tends to make other treatment options more comfortable and more effective. So in the children population, tend to use this for children that you really suspect an allergic component, and you look in the nose and there's these huge boggy turbinates. There is some study data suggesting that there's improved quality of sleep, quality of daytime function, and then decreased use of the need for long-term medications like nasal steroid sprays postoperatively. Another kind of surgical site that we consider, and mainly, these other treatment options are the options that we tend to consider after adenotonsillectomy has failed, are addressing the lingual tonsils, the tissue at the very back of the tongue. Here's a nice kind of before and after picture. You can see that when there's lingual tonsillar hypertrophy, it does tend to have this secondary effect of pushing the epiglottis. And most of the time, there's rarely also an epiglottic component separately. Most of the time, if you adequately decompress the lingual tonsil tissue, then the epiglottis will lay nice and flat. Sometimes the epiglottis itself is the problem, in which case we can do either an epiglottoplasty, where a portion of the epiglottis is removed entirely, and or an epiglottopexy, where you essentially pexy the epiglottis to the base of the tongue. When you're dealing with kind of lingual tonsil tissue, epiglottopexy, plasty, you always have to, of course, talk about risks for dysphagia. But I can say that as long as you are not too judicious in terms of taking all of the epiglottis, generally for otherwise healthy children, there tends to not be a concern in terms of aspiration risk post-op. And then, sometimes laryngomalacia, kind of this floppiness of the tissue above the voice box, is an issue. And so to address that, sometimes we'll perform a supraglottoplasty in terms of impacting both daytime breathing as well as sleep apnea. And so you can see here, what we do in a supraglottoplasty is trim the tissue of the arytenoids, which you can see in kind of the pre and post-op pictures, and then release these aryepiglottic folds. And so the goal is really just to allow the supraglottic structures to kind of unfurl so that you don't have as much tethering and obstruction at the level of the supraglottis. And then, I would say in the past 10 years or so, we've really moved away from tracheotomy. People tend to think about this kind of as like a last line or almost like a failure for sleep apnea. But I can tell you that for sometimes, syndromic children or children that are going to need to go multiple procedures in the future, sometimes a trach is a reasonable consideration either for a temporary period of time or for long-term purposes. So the other thing I wanted to kind of touch on today was the utility and the role of drug-induced sleep endoscopy in children. Sleep endoscopy is a nice tool. We certainly use it on the ped side as well as the adult side. And And it can really help you guide either current or future decision making. Obviously, the downside is that it requires time, resources, and anesthesia. And we have this kind of VOTE classification system, the velum, the oropharynx, the tongue base, and the epiglottis in adults. And we know that in children, if you remember from my initial slide, that classification system is not easily translatable, meaning there are additional sites of obstruction that needs to be considered for children. So there have been several groups that have kind of put together their own scoring systems for pediatric sleep endoscopy. And I'm not sure we have a great consensus. You know, it's still kind of user dependent, but I would say I like this one because in general, these are the sites that I think about as being important for pediatric sleep apnea. So starting, superiorly at the level of the adenoids, and then the soft palate, the velum, the lateral walls and the tonsils, and then looking at the tongue base, and then the supraglottis, as well as, I think about the supraglottic structures, and then the epiglottis as kind of a separate supraglottic structure. And, when people, I think, are still trying to figure out what is really the role for sleep endoscopy in children. And so this was kind of a nice study that looked at how does awake tonsil size compare to the degree of obstruction on a sleep endoscopy, and how does that compare to sleep studies? So where does this kind of fit into our paradigm? And so not entirely surprising, super little and super big tonsils correlated really well to sleep endoscopy, meaning 4+ tonsils collapse and cause an issue. 1+ tonsils rarely do. But, kind of perhaps not surprisingly, this intermediate grade tonsils, these 2+, 3+ tonsils that we see, and we're not really sure how representative, those are to suggest sleep apnea. The DICE was much more helpful in terms of predicting PSG severity. So sometimes, a nice adjunct to use in the OR. I can tell you that in my practice, I tend to use it for children with sometimes very small tonsils to confirm tonsillar collapse. If they have a bad sleep study, but very small tonsils, I'll do a sleep endoscopy and tell family that I'll err on the side of taking the tonsils. And then I'll just confirm with the sleep endoscopy that they are in fact part of the problem. For children that are medically complex, or children that I really think are going to be at high risk for residual sleep apnea even after adenotonsillectomy, those are the children that I'm really using sleep endoscopy for currently. And then the last few minutes here, I figured I would touch and just kind of give you the updates in terms of where we are from an Inspire standpoint for pediatric patients. And basically when it comes to this, to children with refractory sleep apnea or residual sleep apnea, tends to be kind of the algorithm that we follow. Children get an adenotonsillectomy, and then if they're failing, we consider a sleep endoscopy to look for other surgical targets, take the lingual tonsils down if they're large and part of the problem, address any other soft tissue, or even consider palatal expansion or skeletal surgery. And then, what are there any other options? And I think that's really, this is really the place where hypoglossal neurostimulation potentially fits in. So as you may know, the first kind of group of children that this is really being looked at in a systematic way is the Down syndrome population. And this is potentially a really good target for this therapy because of the degree of hypotonia, and also the fact that there is relative macroglossia in these children. And so pushing the tongue, forward is potentially going to be a really nice therapeutic option. So in terms of published data so far, the kind of published data has been on 20 adolescents with Down syndrome that were implanted, and I think 5 different sites across the country. And in Pittsburgh, we are one of those sites. And so it's been kind of exciting over the past few years. And you see, looking at objective pre and post-op AHI scores, significant improvement. There also seems to be, from parental report, improved speech, cognition, school performance, and overall daytime functioning. There's been some question, why would speech get better? Is it just from a neurocognition standpoint, or is it from like actual strengthening of the tongue? To some degree, maybe it's being kind of worked out when the therapy is working overnight. I don't know. I think to be determined on that one. In terms of, drawbacks that we consider for children considering an implant like this, the current iterations, we think the battery usually lasts somewhere in the 10-year range. Maybe you get 15 years out of it, but certainly, they'll require battery changes, surgical battery changes every decade or so. So, when we're implanting people in their, 60s, 70s, 80s, not that big of a deal. But when you're talking about a teenager with Down syndrome, then perhaps, hopefully, significantly more battery changes over their lifetime. Also, you can imagine you have the electrode around the hypoglossal nerve under the chin, and then you have the pulse generator, the actual device implanted in the chest wall, and a wire between the two of them. And so, yes, there's some slack in the wire, but, as children grow, so the neck and the chest grows, will there be scar tissue that forms, or will that wire become a problem at all? And then I did just want to touch on, there were some concerns for the earlier generations of these devices about MRI compatibility, and most current iteration was cleared for full body MRI compatibility. So thankfully that one isn't a huge issue anymore. So currently there's really two big trials going on in Inspire for pediatric patients. The first is kind of a deeper dive looking at neurocognitive outcomes of Down syndrome who are implanted. And I think there's 5 sites across the country. We're one of the sites looking at kind of pretty in-depth executive function neurocognitive outcomes pre and post-operatively. And then there's also a registry that we're one of the sites for, looking at young adults basically who are implanted with Inspire therapy, looking at kind of their 5-year track record. I can say that study is, more difficult to enroll for right now, because obviously, most young adults ages 18 to 21 are not going to jump to, we're not going to jump to an Inspire implant for them. That being said, I think the cerebral palsy population is probably a good target for this therapy as well. I had a 19-year-old that I implanted last week, and so she'll be activated in a couple of weeks. So I'll have to, keep you posted in terms of how she does post-operatively. But some exciting work going on to really see how this therapy can be translated to the pediatric world. So I know that was kind of a whirlwind talk about, how we think about pediatric sleep apnea from the ENT side of things. But, really what we try to do is pinpoint the site of obstruction or collapse. And really, if you can find where children are collapsing, you can generally make them better. And I think we're still figuring out, the role of sleep endoscopy and different surgical treatment options for pediatric sleep apnea. It's kind of an exciting field because, there's so much work that still has to be done. And then oftentimes, this is really a disease process that benefits from a true multidisciplinary approach, particularly for these more medically complex children. So I think pediatric sleep is a great field. If anybody is close to Pittsburgh or wants to come spend some time in Pittsburgh and see my sleep practice, I'd love to have you. And I'm happy to take any questions. I figured I could shamelessly put pictures of my children sleeping. It's a little bit of a stretch, but it's a sleep talk, so I guess I'm allowed. But I'm happy to take any questions anyone has, and thanks for listening this morning.
Thank you, Dr. Whalen. If anyone has questions, you can just unmute yourself and ask, or you can put them in the chat.
Hi, Dr. Whalen. My name is Ian. I'm one of the sleep medicine fellows at Stanford. I was just curious about your experience. I read the initial report of 20 patients. It seems really positive. I feel like that's really different than I feel like what our experience sometimes is with adult patients that get Inspire. Is that kind of reflect what your experience is, that it seems to work really well in this Down syndrome population?
Hi, Ian. You're at like the mecca of sleep surgery at Stanford. So that's a really great question. And so far, the thing is, there's 20 patients, right? So it's such a smaller sample size. It does seem like anecdotally, these patients are actually responding better than the adults. Yes, that's been our experience, at least with, I think 4 total patients that we've implanted so far at our site in Pittsburgh. But I think part of it is, the Down syndrome trial that we're doing right now has pretty stringent BMI criteria as well. And so a lot of the true Down syndrome kids, have a BMI that is above the 95th percentile for otherwise, otherwise healthy children of that age. And so most Down syndrome children are disqualified from a BMI standpoint. So I think to some degree, as practitioners, we're a little bit concerned that this is overrepresenting, the true effect if we were just to say, okay, well, children with Down syndrome qualify for this if they fail adenotonsillectomy and CPAP. So I think, because we're selecting such a select group for the trial, I think the results are a little bit more promising than they might pan out to be in future years. I don't think our Pittsburgh sleep fellows are on the call. That's okay. They've already heard this talk. All right, guys.
Hi, Dr. Whalen. This is Dr. Gupta from JFK Medical Center in Edison. Very interesting talk. And I was curious about your criteria for admitting post-surgery. And it mentioned children under 3 years. Mm-hmm. So what are the particular concerns in that age group?
It's a great question. I don't think we have great evidence. Part of why we tend to admit those children is because we tend to not like to take out tonsils until kids are at least 3 from the risk of bleeding. If they were to have a post-tonsillectomy bleed, just from an overall size standpoint, we tend to worry that it would be more critical. So we just have a lower threshold to just really go slow with those children. But a lot of practitioners like to get a hard and fast rule sleep study first if you're going to consider taking tonsils out under 3. And really, we admit for that same reason, the risk of bleeding.
So the reason why I ask is, should we make that recommendation routinely in our reports when we are studying under 3 years old in the lab, that if tonsillectomy is being considered, then post observation is advised?
I don't think it's necessary, because I don't think it's really related to the sleep apnea or post-obstructive pulmonary edema concerns. So I think because it's, more surgeon concern, I would probably opt to leave it out of the reports.
So it can be based on the surgeon's preference if they want to observe or not.
Yes. So but I would say most centers do.
I see. So is there any reference, like any like a guideline or reference that we can use to help?
That's a good question. I don't know if I have. I can look. I can send to you if I'm trying to remember because we have clinical guidelines to suggest to get a sleep study for children before adenotonsillectomy under 3. Mm-hmm. But I don't know if we have guidelines to say to admit postoperatively.
I see. Okay. Thank you so much.
Of course. Right. Well, thank you all for listening and for thoughtful questions. And Sally, thanks for getting everything set up. I appreciate it.
Thank you, Dr. Whalen. You gave a wonderful presentation and we appreciate it. And thanks to everyone who attended. And we will see you next month. Thank you so much. Take care.
Bye-bye.
Thank you. Bye.
Part of it is, the Down syndrome trial that we're doing right now has pretty stringent BMI